Welcome everybody to the latest edition of Infection Control Matters. Brett Mitchell here, and Martin's joining me today. G'day, Martin.
Hello, Mark. Or even Brett. I don't know why I said
Brett.
that.
I don't even know who I am after all these years.
No.
I'm really looking forward to our chat today, Martin. We've got two special guests with us. Dr. Aline Wolfensberger is a medical doctor, and she joined the Department of Infectious Diseases and Hospital Epidemiology in the University Hospital Zurich in 2012, and has got a particular interest in pneumonia and non-ventilated pneumonia at that. Welcome, and thank you for joining us.
Thank you for the invitation. Good morning.
And we also have Professor Hugo Sax. He's an infectious diseases physician in Switzerland as well, and he's been a leader in infection prevention and control for a couple of decades, and his area of interest and research often focuses on the systems approach to infection prevention control and using human factors engineering and data science and innovation. Welcome, Hugo.
Great to be here. Thank you.
We were just chatting before we started recording, and I said how much I'm looking forward to this discussion today. And the discussion today is on a paper that has just been recently published in the Lancet Infectious Disease, and it's called Prevention of Non-Ventilator Associated Hospital-Acquired Pneumonia in Switzerland, a Type 2 Hybrid Effectiveness Implementation Trial. Long title, but nonetheless a fantastic piece of work. We don't see much work and these types of trials in the area of HAP, or non-ventilator associated pneumonia. And it's great that you've managed to do this piece of work. Before we sort of get into the paper itself and a bit of what you did you want to start off, Aline, by just talking to us about where did you get interested in this topic of hospital-acquired pneumonia?
So since 2013, we in the University Hospital in Zurich, we did yearly point prevalence surveys. So at one day in the year, we looked at who has an healthcare-acquired infection and what kind of infection was that. And we, since that year, like probably many other hospitals, we knew that surgical site infections and urinary tract infections are common in our hospital, but we also saw that pneumonia was always on the first or the second place of the most common HAIs. And we also saw that more than half, mostly 2/3 of all pneumonia were non-ventilator associated. So that was the time that we realized that we should probably invest in prevention of this kind of HAI.
I'm smirking here whilst we're on this call and Martin's smirking back at me.
I'm smirking, yeah.
We've discussed many a time that point prevalence studies done across Europe and Australia and the US have often shown pneumonia and UTIs and perhaps SSIs as the most common infections acquired in healthcare or hospital settings. And yet not a lot often gets done about pneumonia. And so it's really refreshing to hear that you've used the point prevalence data as a way to think about what interventions you might want to think about to prevent pneumonia.
Yeah, I really love this moment when you discover something that's actually hidden in plain sight. And we just
exactly,
saw this cake graph and the proportion of pneumonia, and then discovered that half of them are really not ventilator associated, which was taking all our focus in the past.
I can remember being in an ICPIC meeting a number of years ago now, and I can't remember who it was. They were presenting the results of the ECDC point prevalence survey around at that time, and pneumonia was the number one. So when it came to questions, I said, okay, so what's the action? And everyone's looking side to side. And there wasn't any, and no national guideline appears anywhere in the world, and there are no national interventions. So it's just really good to see an organisation looking at its own data and saying, right, we need to do something about this in a really well, run study. So that's fantastic. Mm. Honestly, I'm so pleased with this.
So, Hugo, your study, this was a sort of single-centred implementation study done in 9 wards in Zurich. Just want to briefly just tell us a little bit about the design itself and why you decided to use that type of approach?
So the study design we used
the study design.
Experimental design. We used the stepped wedge study, non-randomized. Initially, we thought about, can we randomize the start of the implementation of the 9 departments? But we quickly realized that in this real-life study, this was not feasible. So the whole study, maybe I can talk a bit about that, took place within a hospital-wide initiative to lower HAIs. And prevention of pneumonia was one of the elements. We've targeted also other hospital-acquired infections. And in these 9 departments where pneumonia was a problem, or who had more above average numbers of pneumonia, so these 9 departments invested in pneumonia prevention, and they had to be ready to start the implementation. So if they were not ready, I think we would not have been that successful. So we let them choose the start of the implementation, and that's why we had a non-randomized start of the stepped wedge study.
It was on my mind. I wondered what the reason was for that non-randomization approach, given you went to that great effort of the sort of step wedge design, and that makes sense given the type of implementation style design that you were really wanting to achieve, an engagement with people. Before we sort of get into the ins and outs of the study in terms of what you did, what was the intervention that you were really focused on? What were you hoping to improve or change as part of the intervention?
So the prevention bundle consisted of 5 prevention measures, which were oral care, dysphagia screening and management of dysphagia in patients, mobilization, stopping non-indicated proton pump inhibitors, and respiratory therapy. So these were the 5 main prevention measures, and there was an overarching implementation strategy that we applied. We had our team, so the hospital hygiene team of our department. We were 3 people who were mainly responsible for implementation. This was a study nurse, an implementation scientist, Professor Clack, and also me as a physician. And on the other hand, all of the 9 departments, we had also 3 people, a physician, a nurse, and a physiotherapist who were engaged in implementing this bundle in their department.
The important thing was that we wanted the departments to be independent and in charge of the implementation. So that was an important idea, that they take ownership of and have the occasion of adapting the implementation strategy to their needs.
We might delve into that a little bit more in a minute. Just on the components of the intervention, the components of the bundle, a couple of things struck me. One was about oral care and the other was about proton pump inhibitors. With oral care, I noticed that sort of the target was to try and get to once a day oral care provision. Was there any reason why that was particularly chosen? Did you see that as being feasible, or what were the reasons for that sort of number?
I mean, everything was kind of pragmatic in this study or project, and that was also a pragmatic approach. We thought, or we and the dentist who also was in our team counseling us about best measures to choose, we thought that once a day well done is better than 2 or 3 times a day not well done. And so we chose to go for once a day in all of the patients, and that's, I think, still really important, is the 3 times a day for patients who have swallowing difficulties. So.
And the proton pump inhibitor component of the intervention, what was the rationale for that?
Yes, so we knew from studies that some studies show an association of proton pump inhibitors with pneumonia, others don't. we still included this measure as a prevention measure because we thought it can't be wrong to reduce PPI. So if we maybe don't have a large effect on pneumonia, we prevent administration of medication that is not necessary or may have other side effects. And also important was that we wanted to engage all three professions, so nurses, therapists, and physicians. And this was clearly a physician-centered prevention measure. And it was important for us to engage them too. And so we kept this bundle element in, even though we knew that it might not have a large effect on pneumonia.
There is the systems thinking approach of implementation that it's not maybe a direct effect, but there is an indirect effect of having everyone on board in this endeavor.
They're much more likely to be engaged, aren't they? Because many of the other measures are quite nurse-focused. So if we take, for example, the oral care, that's almost a bundle within a bundle, isn't it? It's making sure at least you're going to get your mouth attended to once a day, but also somebody's got to do the assessment to determine whether you have gingivitis and you maybe would need the chlorhexidine. So how much training did you have to do with the nurses to bring them up to speed with oral care? Because I know from a study from Mark Garvey that I was involved in last year, they actually put a dental nurse on some units to actually teach all the staff about oral care, because you'd think that was fairly intuitive, but it turns out it's not, and they learnt a lot. So can you talk about the education needed to actually bring everybody up to speed beforehand? And then I'd also like to know, do you have any idea what oral care was like pre-intervention? In other words, how many people weren't getting their mouth attended to even once a day, and what proportion were actually needing the chlorhexidine as well?
What was done exactly in the top departments really depended on the departments, and some invested a lot in oral care education. Some invited a dentist to do training for a large nurse group, and others focused on small group training and so on. So at that time also there was oral care standard operating procedure published in our hospital, and this was a bit kind of hand in hand going with our bundle. We were lucky on that side. And yes, so training and education was really depending on what was the need of the departments, and that differed a lot. Some departments were already quite good and others needed more education. And the second question was about, sorry, I forgot it.
I'm just wondering how much oral care was going on pre-intervention in your baseline period. What proportion of patients weren't getting oral care at all?
So that's a difficult question to answer. So we tried to monitor adherence to prevention measures in two ways. We had these 50 patients that we looked at a bit more in detail 4 times during the study period before intervention and 3 times after implementation started. And there we looked first in the medical records and see if there was an oral care episode documented. And if not, we went to visit this patient and ask if he or somebody brushed his teeth. So if normally if a nurse brushes the teeth of patient, she documents it. Normally, but not always. And so we tried to find that out. And adherence was, to the oral care prevention measure was already quite high before start of the intervention.
I really like those questions, Martin, because we're sort of we're sort of 12 months away, but embarking on an RCT here in Australia to prevent multi-centre RCT to prevent pneumonia. And the key focus of this is going to be improving oral care. And one of the things we're really trying to think about is how do we capture these data about how frequently oral care is conducted without biasing the intervention phase by inadvertently talking about and inadvertently putting in an intervention, at least influencing the potential outcome by talking about oral care in the control phase. So I did like that convenient sample approach that you use, because I think that would help reduce that bias. Is that one of the reasons why you sort of took that approach to try and reduce the risk of bias of affecting the primary outcome?
Yeah, so you're addressing the step wedge design, I guess here. This is really coming from public health research and intervention, that you want to, everyone has the hope to get the perspective to get included. So the control, the people who have not yet the intervention, then don't have so much an inclination to look over the fence and see what the others do that have the intervention, because they kind of, in an RCT where you have controls all along, they despair. They think they're left out. And so this is one of the advantages. The other advantage is that you have an intervention period in some of the groups in parallel to have the control over time. And so this gives the opportunity to calculate if there is an influence over time that's not attributable to the intervention.
Could you tell us a bit about the mobilization part of the intervention? You know, how did that differ from what was standard care, if you like, or usual care, and how did you get people on board with that?
So in mobilization, we asked for mobilization twice a day, out of the bed, ideally, or at the bedside in patients who cannot really leave the bed. Actually, that's more or less usual care. It's not that usually. Okay. We all know that patients are ideally mobilized, but still, what we know from reality that mobilization is sometimes very time intensive and is left out if there are not if there's a lot to do on board.
It's staff intensive, isn't it? Yeah.
Exactly. So here we had this minimum of 2 times a day, and we really just try to educate about the importance of mobilization, why it is important, why it can prevent pneumonia, and of course also other side effects of a hospitalization. So it was not much more than usual care, but it was that we wanted to increase adherence to this usual care.
Or at least know that it's happening. I mean, the patients who weren't getting out of bed, were they doing anything like passive limb movements or anything like that to try and get the large muscle groups moving?
Yeah, if not possible that the patient moves out of the bed, of course it's passive movement or patient positioning in the bed. That was a learning we had from our study, that this might be a bundle element that we would include in the next study, that the patient positioning might be even as good or as patient mobilization in certain patients.
One of the things I mean, there's lots of things I loved about this paper. One of the things I liked, and for those when you listening who get a chance, if anything, I encourage people to have a look at the figure 1 in this paper, because it really beautifully summarizes the whole study, I think, with the sources of data that you were, the data sources that you were using, the measures and the analysis that you were undertaking, and breaking that into both the effectiveness side and the implementation side. And so you could really look at whether there was success in implementing some of the components of the bundle, and also, of course, the effectiveness of the bundle with regards to things like the incidence of pneumonia and inpatient mortality. And one of the other things in your paper, you sort of really beautifully describe the before and after, if you like, or the time series of data around the process measures. So oral care dysphagia, mobilization, and how they were looked and tracked with adherence over time. On reflection now, what do you think are the sort of determinants of the success of the implementation? What do you think were the critical things about getting good compliance and adherence to the intervention itself?
So I think one of the most important elements is what we mentioned before, that the departments have a certain independence and accountability for what they were doing, and ownership. And the second overall element was probably that the qualitative inquiry, the results were always fed back to the departments as ideas how they could improve over the time. So it wasn't like the typical randomized prospective trial where you have to stick to the method all along, and the quality measure is that you don't change the intervention over the time. Here it was the contrary. It was like feeding back what you call formative qualitative research. More specifically, there were some really interesting finding in the determinants for success. One being, if the department was interested as a medical specialty into pneumonia, they did better. Also, if they perceived that their patients were at risk for such pneumonia. So this awareness and this alignment with their specialty was important. Moreover, we found that teams that were architecturally, locally close together did better, which is interesting overall for how a hospital is designed. So teams that are spread out over the hospital in different wards, they have a apparently harder time to implement something, and the effort has to be higher. And then also a kind of complexity system thinking, where you find leverage points that for success is that the personality of the leader of the team, the local team, intervention team, was really important. If this person was a likable person, if they were a finisher, if they were well implemented in the department. And that's something that might be neglected to choose anyone to do it, and not pay really attention to who that person is.
I mean, how did you choose the leader of the team then? Were these people who volunteered within the department to take part in the research, so therefore they had an element of enthusiasm for it at the beginning? Or sometimes were they told you're the team lead? Because we have link nurse programs all around the world, and sometimes you're told that you're the link nurse, and sometimes you're volunteered to be the link person. And there's an old saying in the UK from when the Navy used to steal people, is 1 volunteer is worth 10 pressed men. So how did you choose the team and components and the leaders? I'd be interested in that.
Actually, we did not choose. We had these 9 departments, and they were chosen by their department head or head nurse. We don't exactly know in some cases. So it was not us, and it was exactly how you explained. Some probably were chosen and others volunteered.
It'd be interesting to know if they then would have been a volunteer by the end of it, if they're recognising what's going on. And I know they were feeding back to you because there was really good communication, because I've seen other work that you presented from this. Could you give an example of where they've said straight away, this isn't working for us, we need to change it, and here's an idea that we could implement, and that could then be cascaded to the others?
One example was oral care in patients who could do oral care themselves. We heard quite at the beginning of our project that nurses saying, I don't tell my adult patient he has to brush his teeth. He's old enough. I don't want to do that. I don't feel comfortable doing that. So there we realized that we probably have to take another approach to address these patients. And we came up, or together also with these departments team, we came up with the idea to put stickers on the mirrors in the bathroom, informing the patients that pneumonia, so that oral care or toothbrushing is not only important for their well-being, but also could prevent pneumonia. And that was one example of formative approach.
Brilliant.
I love it. You know, today I was just talking to a consumer and I was asking him exactly that question. What would you like as a patient to help focus you on the importance of oral care and brushing your teeth while in hospital? And, you know, it was quite simple because he just didn't understand the risks. And he said, once I understood some of the risks, then I'm more motivated to actually go and brush my teeth. So I really like that that sort of simplicity of the message there. That's great.
There is a nice story about the toothbrush. We also decided then to give patients or to produce a toothbrush with a slogan in it in a plastic wrap, and distribute it to patients who were admitted as an emergency and didn't have the toothbrush with them. And at the same time, do some awareness raising for the reason, as you just said. And I have such a toothbrush now with me. And when I give talks, I take it with me to show it to everyone, because it took us really 2 years to implement this toothbrush in our hospital. And I show it as an example that implementation is not so easy sometimes. There were many obstacles, sessions, people who had to agree to it and design it and so on. So it took really 2 years.
Can we talk about some results now then? Because
yeah. I mean, we have talked about results now, but in terms of the effectiveness,
hardness, the effectiveness, yeah.
So what was the main results with respect to the incidence of pneumonia and inpatient mortality?
So the results regarding effectiveness of the bundle was that we, over all 9 departments, we had a reduction of NVHAP incidence rates from 1.4 to 0.9, which is a 31% reduction. Wow. That was really great.
These are pneumonias per 1,000 patient days.
Exactly.
That's remarkable. I might come back to a question about the diagnosis of pneumonia in a minute, but what about inpatient mortality? Because that was one of your other outcomes that you were looking at.
So we did not see any statistically significant result in mortality. Probably that was what we expected, because mortality, we know that about 30% of patients with NVHAP die in the hospitals, about half of them. So this is 15% overall because of NVHAP or in relation to NVHAP. So probably we just did not have the power to see any results there.
Did you think about or look at transfers to the ICU with patients who might have developed HAP on a ward? Was that something that you thought about at any point?
Not during this study. We tried to quantify that in another project, but not in this project that we published in Lancet ID now.
I wondered also, have you had any change in prescribing? Were there less antibiotics prescribed because you had less pneumonia? Because people have suggested in the UK there's less antibiotics used, and you actually get an associated reduction in C. diff infections as well.
Yes, so that would be a very interesting outcome to look at, but we did not. Maybe next time.
Maybe next time.
Yeah.
We could still. You could still
go back and look,
because absolutely. There is something to be said about the end of the study, because our idea was to let it run afterwards during the intervention phase much longer, but it was cut short by COVID that took all our efforts in another direction. And we were really lucky to still be showing that the intervention was effective.
I mean, because towards the end of the study, a few units had only just joined it, really, when COVID hit. So actually, if you did well to get a 30% reduction, really, with not everybody joining for a longer period of time, and that may have been much more significant had it run a bit more. So you were a bit unlucky, but in some ways lucky that the intervention seems to be so effective that even with a relatively short intervention period for some, you still got a result. You also say you got some correlation between how well people are implemented and the reduction. Could you just mention that as well? Because I've always felt that if you actually do things, they do tend to work rather than not doing them.
Yeah, so we out from the qualitative data, the interviews, we extracted a graduation, a quantitative measure, and this implementation success measure then correlated to the success in the departments.
I want to go back to your definition of pneumonia just for a second, because this is such a difficult one for people face across the world. You use the ECDC definition for non-ventilator associated pneumonia. How did you find using that definition? Was it okay to use in the context of this trial, or would you want a variation of that?
Yes, so with pneumonia surveillance, you always have this issue that the diagnostic criteria are not objective or not 100% objective. We started in 2017 to do a continuous surveillance of NVHAP using the ECDC criteria. We have a semi-automated surveillance, so we have a computerized algorithm that selects us patients who then have to undergo manual review. We know that we are quite sensitive, and we kept on using this ECDC criteria, which is a radiologic criteria, fever, leukocytosis or leukopenia, and some respiratory signs and symptoms. And that's what we stick to, knowing that it's not 100% objective.
Yeah. Just on the algorithm that you mentioned, our other colleague on this podcast, Phil Russo's ears would have pricked up at that one, because he's very much into some automation of surveillance of infections. Have you published that piece of work?
Yes, we published the development and the validation of this semi-automated surveillance system some years ago.
We might include that on our website for readers so that they can have a read of that one as well. Now I'm conscious of time, but I could talk all day.
I need to butt in though.
Oh yeah,
I just need to ask, because you're right that when you look at what the difference between baseline, implementation, intervention for things like oral care didn't change much, although it did increase, but not significantly. But the one that jumps out to me is the bedside dysphagia screening. So it seemed like there was almost none going on before. And then, so was that a result of people recognising that actually this is something we need to do, or was it something more formally put in place? And do you think that's been maintained since?
Yes, so this was the prevention measure that was not really newly implemented in 7 of 9 departments. 2 already did some dysphagia screening due to their patient population they have, and others really implemented it from the scratch. And I think, and some even said, we do it in all our patients. At admission, we do it in all of them. That's easy. We don't select the patients who need the screening. We just do it overall. And these departments still do that. And I really think that was one of the prevention measures that was more or less sustainably implemented. And probably had a large effect, because these patients, older patients with neurologic diseases, they can be all over in the hospital, maybe having a surgery and so on. And I think that's really important to identify them early and act on somebody who has a dysphagia.
Great. Just maybe like a final question from me. If you were to do this study again, or if you were to give some advice to someone who's thinking about doing a study similar to this, would there be things you'd do differently, or things that you would say, I'd love to do this next time, it would be great if someone could do this? Any advice for future work in this area?
Maybe our bundle would look a bit different now after several years of publications and things we learned. For example, we did a risk factor analysis in our patients of our hospital, and we found out that one of the most important risk factors for developing an NV-HAP is having a feeding tube. Mm-hmm. So these patients, we kind of forgot a bit, and we probably would now put feeding tube management into the bundle. I would set the goal of mobilization a bit higher than twice a day. Mm-hmm. And what I think is also very important is to do good pain management, and still by preventing any sedative effect of medication. Mm-hmm. So this would be a bit of an adapted bundle.
Would you go higher on the oral care front? Would you want to up that from once a day, or you think you got your bang for your buck at once a day?
Maybe I would go to twice a day, because that's what we learn as children in school, twice a day. That's the goal of oral care. Maybe I would do twice a day.
I think what we learned regarding the monitoring of the adherence, I would probably now register more the quantity of the investment of the adherence, not only yes, no, but actually how many times or how well something is done. Because I think the what is not shown in the number is that the awareness that was increasing made probably, and there is some indications in the qualitative data that people did it better or more often, which was not really captured well.
Well, it's fantastic having this chat with you both. Thank you so much for your time. Martin, is there anything else that you wanted to ask before?
I love this study. I've been, reading the various papers coming out, and I think the local implementation teams was the big thing for me. The feeding back of this doesn't work, we need to change this, and we can't do that, or maybe can we do it in another way, and then being able to share that with all the other implementation teams. So I thought that was really good, rather than just saying, here's a protocol, start it on Tuesday, and I'll be back in 6 months to see if it's worked, which is what I would have done 20 years ago, which explains why nothing ever worked. So I was fascinated by it. So I'm really grateful for the chance to chat to you both, Hugo and Aline, because I've been following this one for quite a while.
Absolutely. Thanks again.
Thank you for the occasion.
Thank you. It was a pleasure.
The pleasure is all ours. And thanks everyone for listening to the latest edition of Infection Control Matters.